time ado, I will start with the first presentation. It is about inflammatory CNVMs. The presentation was by Colonel ASHOK from Armed Forces Medical College, and I'll be presenting on his behalf. Very good morning. So we'll be talking about choroidal neovascularizations, which we all know are the growth of choroidal capillaries through a break in Bruch membrane under the RP or the neurosensory retina, classified as type 1 and 2 respectively. So a wound healing process after a break occurs in the Bruch membrane is what is responsible for the occurrence of a choroidal neovascular membrane, and they can be degenerative in elderly people, while in the younger population they are mostly either associated with myopia or with inflammation. Rarely we see post-traumatic or angioid streak associated CNVMs. Now, the inflammatory CNVMs are also a very important part of the milieu of patients which we see in armed forces, especially we deal with a younger population. They are sight-threatening to the patient as well as lead to loss of productivity to a great extent. So talking about the non-infectious uveitis which have been reported to be associated with inflammatory CNVMs, we have most importantly multifocal choroiditis and punctate inner choroidopathy. Both of them to a tune of 30 to 40% cases over the lifetime of the patient have been associated with some form of foveal or extrafoveal CNVMs. The list also includes diseases like AMPPE, birdshot chorioretinitis, and MUDES. Talking about VKH, close to about 10% cases of VKH over the lifetime will develop choroidal neovascular membranes. In cases of panuveitis, Behçet and sarcoidosis both have been reported to be associated with CNVMs. Talking about the miscellaneous causes, the idiopathic panuveitis again remains an important cause. In our country, nothing can go without the discussion of tuberculosis, and post-tubercular CNVMs form about 10 to 25% cases, while in the Latin American region, toxoplasma forms a major component. We should be aware that in younger population, when we are dealing with foveal toxoplasmosis, CNVMs are bound to occur at some point of time, and therefore in these cases we have to be a little careful. So the risk has been reported to be about 2% in a cross-sectional study. However, when we compare the causation of this disease, it appears that in almost all cases of choroiditis, the pathway for CNVM has already been created, and it is just a matter of time when these people will throw up the disease. So they have to be under continuous monitoring. VEGF plays a major role in the pathogenesis and also remains the key place where we are able to target this disease. The pathogenesis includes the major role played by tumor necrosis factor alpha, interleukin 1, nitric oxide, and transforming growth factor beta. The clinical presentation is that of metamorphopsia in a patient who till now was only complaining about diminution of vision. So an alteration in the symptomatology of the patient is the first pointer, and dilated fundus evaluation where we are able to see a CNVM with an associated hemorrhage is usually a giveaway. Now coming to the diagnostic modalities, this is the classic FA where we can see early hyperfluorescence in the choroidal phase itself in a pre-existing choroiditis patient. Now this has been reported by the team at PGI about tubercular serpiginous-like choroiditis associated with CNVMs, and ICGA has been the baseline investigation in most of these cases. On ICGA, we can see that as the late phase appears, the CNVM becomes more prominent. Now ICG helps, but OCT remains the backbone of our clinical screening of these particular patients, and these features, whenever they are present, especially when we see any amount of subretinal or intraretinal fluid, leads us to a suspicion of CNVM. Now in this case, the classical pitchfork sign could be seen, and this is a tuberculosis associated CNVM. The arrival of OCT angiography has solved this mystery to a great extent, where we are now able to delineate a choroidal neovascularization over the choroiditis scar. And here we can see that either it can be in the classical C-fan configuration, mostly peripapillary in origin, or it can be in the Medusa head pattern, which is commoner in the foveal region. Now this is a case of multifocal choroiditis, where we can see that a CNV has popped it in the frame on the top, and after administration of ranibizumab, the CNV has resolved, the IRF has disappeared, the patient's vision improved substantially. Now the same thing when we see on an OCT angiography, where we can see the entire branching vascular network, it has shrunk over a period of time after administration of anti-VEGF, and this gives resilience to our diagnosis that yes, the diagnosis of inflammatory CNVM are correct. So OCT angiography has proven superior to FA, ICG and OCT in most of the studies. So whenever you find this complicated case of inflammation of the posterior uveal tract associated with CNVM, don't shy away from ordering an OCT angiography. Also some role is played by autofluorescence, and we can see this classical appearance where we find that the CNV becomes a hyper ring associated with the hypo surrounding. The differential features between the AMD and the inflammatory CNVM or AF have been described. For the sake of time, I'll skip through the treatment modalities, but the baseline remains that we have to control the inflammation and the CNVM using a combination of anti-VEGF and steroids. Thank you so much. Any questions, please?
Yeah, please.
Please.
In presence of vitritis, I fear of giving anti-VEGF. Can we give, because I have seen one of my patients having CNVM.
Yes.
It is posterior uveitis.
So that is one place where we definitely recommend a combination of steroids and anti-VEGF. Though it is being frowned upon by most people that why you are giving an Ozurdex and any of the anti-VEGF at the same time. But this is the classical situation where you will be able to control the inflammation. With the control of the inflammation, the steroid also has an anti-angiogenic role. So even if you give a steroid alone, it might help in resolving the CNVM. But if you add up any of the anti-VEGF, barring say something like brolucizumab, it is a wise option.
Also, the challenge which comes is with documentation with OCT, it becomes difficult because media at times is not clear.
Very true, and that is why the role of ICGA, because ICGA is able to permeate through most of the media haze of vitritis, as well as if you have a overlying blood on top of the retina, the ICGA can see through it. So that is why now it is resurging back as a very important modality.
But challenge is the availability.
Yeah,
Availability.
that is the thing.
We don't have OCTA also. So just started with.
Totally agreed. So that is why I say that when we have these complex cases, these are 2% of our entire clientele of CNVMs, when they present to us, we should not shy away from a referral, because otherwise we end up burning our fingers with these cases.